Hi, everyone. Welcome. My name is Margareta Brandt. I'm the Assistant Deputy Director for Health System Performance here at the Office of Healthcare Affordability. And I use she, her pronouns, and I'm going to bring up our presentation in just a second. And as we always do, would love for you all to introduce yourself in the chat with your name and your organization and your title. And we appreciate all of the introductions in the chat as we get started. Maybe can someone just say if they see the slides okay? Okay, thank you. Okay, so we'll move to our agenda next. So on the agenda today, we will, of course, we started with welcomes. We'll do a few updates and introductions. And thank you all for your introductions in the chat. And our main first agenda item is a summary of what we've heard from stakeholders so far about our behavioral health work stream. And spend most of the meeting discussing a proposed behavioral health investment benchmark framework. And then, of course, before we adjourn, we will preview our agenda for the December work group meeting and some next steps. So this will be a discussion-heavy meeting, so we appreciate all of your engagement and interaction. And this slide is just, again, a reminder of our meeting format. And as always, we appreciate all of your comments and thoughts in the chat. We aim to respond to as many of them as possible and bring them into the discussion. But if we aren't able to respond to all questions or comments in the chat, we take note of them and we incorporate them into our work moving forward and are happy to answer any questions between meetings as well. And I think, yeah, then we can move to our next slide, which is, again, just a quick reminder of our work group members and the range of perspectives that they represent. And with that quick introduction, I will turn it over to Debbie to walk through the stakeholder feedback that we've heard to date on the behavioral health work stream.
Sorry, I had to unmute myself. Thank you, Margareta, and good morning. I'm Debbie Lindis. I'm the manager of the Healthcare Delivery System Group at the Office of Healthcare Affordability. I use she, her pronouns. And over these next few slides, I will be reviewing the feedback we've received so far on the behavioral health work stream from our past work group meetings here, our stakeholder interviews, the advisory committee, and OHCA's state government sibling departments. So as we've discussed in the past couple of meetings, how we ultimately decide to measure and set benchmarks for behavioral health investment really depends on the goals that California wants to advance through this investment. So regarding those goals, we have heard that prevention is important to a well-functioning behavioral health system and better outcomes, and that not all prevention occurs within the healthcare system. Stakeholders have highlighted that more behavioral health spending, such as spending on institutional care, doesn't necessarily lead to better outcomes. We've heard that access to care is a critical goal, especially access to therapy, peer support, wraparound services, and other community-based services. Stakeholders have emphasized affordability as a goal for our measurement and benchmarking work, and that in particular, evaluating out-of-plan spending is important to understanding the actual cost of care to consumers. In terms of our process, some stakeholders have suggested that we engage additional stakeholder groups, such as clinical professional organization representatives, behavioral health providers who are not in managerial roles, emergency medical services personnel and other crisis responders, and people with lived experience of behavioral health conditions to ensure that we incorporate all their perspectives as we're developing our approach to measuring and benchmarking behavioral health spending. Regarding our measurement of behavioral health spending, we've heard that we should be clear on our goals for measurement and balance those goals with data submitter burden and data quality. In striking that balance, we should consider whether there are alternative sources of data and analytic capacity to answer our policy questions. We've heard a strong preference to measure substance use disorders and mental health conditions separately, and to include all clinical care settings in our measurement of behavioral health spending. Stakeholders have raised questions about whether and how to incorporate diagnosis codes into the measurement approach. And regarding the behavioral health and primary care module, stakeholders have asked about and offered their views on how to define the module. They've expressed some concerns about the availability of primary care clinicians with training in behavioral health care, and have shared that care management and care team infrastructure may not be sufficient to support the need for this type of care. Stakeholders have also noted that it's important to capture behavioral health spending via telehealth, as well as spending under global and professional capitation arrangements and spending by carve-out plans. There have been requests for OHCA to look into data availability for behavioral health services that are provided through employee assistance programs. And stakeholders have pointed out that inclusion of some types of services, such as applied behavioral analysis, or ABA, could distort our spending measurement. And finally, for the benchmark, we've heard that while stakeholders prefer that data be collected in a way that allows spending on mental health and substance use services to be measured and reported separately, they've also asked that the benchmark incorporate both these categories rather than having separate benchmarks for mental health and substance use. We've heard a strong interest in a benchmark that prioritizes access to the most appropriate care setting for a given situation, that focuses on certain care settings, more specifically that focuses on outpatient community-based behavioral health care, and that reflects evidence-based, high-quality behavioral health care. Stakeholders have expressed mixed interest in a benchmark that focuses on certain diagnoses or diagnostic categories, or that focuses on certain populations or providers. So I'll pause here for any questions and discussion about the feedback that we've heard so far. Feel free to raise your hand or unmute. Catherine.
I just had a question on this slide about the first bullet. I'm not sure I totally understand the do not separate in defining a benchmark. And this is a question for everybody because others may have had strong feelings about that.
Sure. So just, and Margareta or Mary Jo can chime in as well, but and we'll cover this a little bit more, that with behavioral health, unlike with primary care, we're going to be drawing a distinction between measuring overall behavioral health spending and then a focused benchmark that will be targeted. And so what we've heard is that although people want to make sure that we can measure and separate out how much are we spending on mental health versus how much on substance use disorder treatments, that our benchmark, our kind of policy-focused benchmark, may want to incorporate both of those. And we'll talk a little bit more about that later. So please bring it up again if it remains unclear.
Thanks.
Yeah. Go ahead, Beth.
2 points. Not on employee assistance programs. That seems to me a bit of a distraction from the focus here. But I'd like to know more about the availability, since I don't think they're very common. They don't exist in the individual market or the small group market, as I understand it, or Medi-Cal, or Medicare. So it's just sort of a, what role do they play, and are they an appropriate delivery? Second, I had the same question Catherine had about grouping mental health and substance abuse treatment for purposes of the benchmark. But in thinking back on our previous conversations, a number of people pointed out how comorbid those are and how often that it's a matter of diagnosis coding rather than and doesn't necessarily reflect the amount of care people are getting. So I think I understand. I'll be interested to hear the rest of the discussion, but I'll be interested to hear that. Thank you.
Thank you. Go ahead, Carrie.
Thanks. Just on, I had a similar question as well. So I with Beth, appreciate that conversation. On stakeholders, is that when you mentioned talking with folks with lived experience, does that also include peer support specialists, other, community health workers, other types of providers that might also have lived experience and are based in community?
Yeah, thank you. That's a great flag, and other group that is part of what we would want to cover in developing our benchmark. So thank you for bringing that one up.
Yeah, thanks, Carrie. And I think I'll just note on that based on our conversation in the advisory group to introduce the work that we're doing on the behavioral health investment benchmark and measurement, that those were specific suggestions from the advisory committee, the OHCA advisory committee. So if you all have additional suggestions, we welcome that feedback, and we'll be thinking internally about how we can best engage those folks, whether that means bringing them into this work group or having more specific one-on-one discussions with different folks, both that suggested by the advisory committee and suggested by you all.
Great. And thank you so much, Margaretta. And I think to that point too, it would be helpful, or we would love to ensure that for folks with lived experience, that we're also looking at folks who speak different languages, different demographics, just because there are such differences in terms of utilization and other and follow-up care. So just putting a pin in that too. Thanks.
Thank you.
Any other comments before we move on? Okay. So now we'll move on to our second agenda item, and I'll be joined by Mary Jo Condon from Friedman Healthcare to present OHCA's proposed behavioral health investment benchmark framework. I'm going to start with some quick reminders about our overall measurement approach. As you've seen before, OHCA is proposing to use 3 modules to measure behavioral health spending. And these are behavioral health care paid via claims, behavioral health care paid via non-claims, and behavioral health in primary care. The behavioral health in primary care module will be measured separately so that it can be included in analyses of either behavioral health or primary care spending. For measuring behavioral health spending, this module will be combined with the behavioral health claims and non-claims spending modules, as you see on the slide here. And as many of you remember, the work group helped OHCA define the behavioral health and primary care module as part of our primary care workstream. So we're spending time in the work group at our last meeting and today focusing on the benchmark framework, because that will guide our methodology for identifying behavioral health spending to be included in that benchmark. After today's discussion, our next few meetings will focus on the more technical definitional work of setting the parameters for the behavioral health care paid via claims and non-claims modules. And we'll also revisit that behavioral health and primary care module to consider whether any adjustments are needed. Again, as a reminder, this is our proposed phased approach to defining and measuring behavioral health spending. Our initial measurement, definition, and data collection will focus on the commercial and Medicare Advantage markets to reflect OHCA's data collection approach. The next step will be to adapt the commercial market definition to the Medi-Cal market, possibly adding data sources that are specific to Medi-Cal and making refinements as needed. And of course, we will iteratively revise the definitions over time as we learn from experience. And so last, before we move into discussing the benchmark framework, I want to emphasize the different ways OHCA will use the data it collects. As our statute requires, we'll be measuring total behavioral health spending as a percentage of healthcare expenditures. This measurement allows OHCA to report overall behavioral health spending at a given point in time. In contrast, the benchmark is more of an instrument for achieving policy aims. It's an opportunity to focus attention and effort on a desired outcome. For example, an increase in the relative amount spent on outpatient and community-based services. And this is why OHCA is proposing a behavioral health investment benchmark that includes some, but not all, behavioral health spending. So we'll want to keep this in mind as we move forward with today's agenda and in future meetings, because we'll be moving back and forth between these two uses of the data to define what should be included in each definition. And now I will turn it over to my colleague Mary Jo Condon of Friedman Healthcare to lead our discussion of a proposed framework for our benchmark.
Thank you, Debbie. Good afternoon, everyone, or morning. My name is Mary Jo Condon, Principal Consultant with Friedman Healthcare, and I use she, her pronouns. Debbie, I don't think that I am able to advance the slides today, so if you wouldn't mind advancing as we go along, that would be wonderful. We're going to start with just sort of an overview of today's discussion. So OHCA has developed a straw model framework for the behavioral health investment benchmark, and this has been informed by the stakeholder input that Debbie reviewed just a few moments ago. The straw model addresses four questions. What should increased behavioral health investment achieve? How should OHCA structure the benchmark to achieve this aim? How should the benchmark be focused? And also, what supplemental analyses could support monitoring whether the aim is achieved? Today, we'd like to test this framework and explore these questions with you. And the upcoming slides focus on each question individually. So we'll pause at each slide to hear your thoughts. All right, let's go to, here we go. So the first question here, what should the increased behavioral health investment achieve? In terms of what the increased behavioral health investment should achieve, OHCA's draft proposal is that the increased investment should help individuals in need of behavioral health care to receive more timely care in more appropriate settings with less out-of-pocket spending via improved access to in-network, outpatient, and community-based services. And so I'm going to pause here for a second and get your thoughts on whether or not this reflects your perspective on what the increased behavioral health investment should achieve. Yes, Beth.
Thank you for this. There's a lot to like in this. I think two things I would suggest, and one of these is going to sound persnickety, but it tripped me up. So I think we all know that there's a lot of out-of-network spending that should be occurring should be covered benefits, and total healthcare expenditures, which the law requires you to measure, only captures in-network spending generally on covered benefits. So I would, the comma between in-network and outpatient tripped me up. So I think you mean via improved access to outpatient and community services, community-based services that are in-network. And I think I'm sorry to be finicky, but 10 years from now, people won't have had the benefit of this discussion, and it'll be important to have clarity on that. And I'm sure there's other wordsmithing. The other thing that's been raised with me is we do want to be able to make sure that the care is not only in the appropriate setting, but that it's of the quality that people need. We had a long discussion yesterday at the OHCA board about the paucity of quality measures for behavioral health. And today that's true. I hope in 10 years it's not true. And so some sort of inclusion of the mention of the quality of the care that people are getting would seem an improvement. But this basic framework of people, this is what we want for physical health. It's what we should want for behavioral health, which is people getting the care they need in an appropriate setting, whether that's the community, home, or there are times when people need to be inpatient, that we get them the care they need when they need it, and at a reasonable cost. So thank you.
Thank you, Beth. Carrie.
Thanks. I would echo what Beth shared. I think the one other, and as we think about quality and timely care, I think it's important to also mention culturally and linguistically responsive care. Happy to debate that in terms of the spending, but I think one thing that we're very concerned about is that the lack of cultural congruency in this field results in more people paying out of pocket to find that one provider that speaks a particular language, and we're not really going to and similarly to have better outcomes with peer support specialist or someone with lived experience. And so I think we're not going to, necessarily achieve those measures and metrics if we're not explicit about that being a goal in how we're in our spending, the way we want to be spending in this area.
Excellent. Thank you, Carrie. Yes, Catherine.
100% agree with that as a goal, and just want to raise that from what I know, we have so little data by which to measure that particular point that it gives me a little bit of concern about having a goal that that goes way beyond what we can actually measure here. So I'm not sure. I would love to have it included in some way, but also be really clear about, and maybe this comes later, what we are and aren't able to measure at this point. On the other hand, and maybe we can be more expansive in our intentions. So mixed feelings.
Excellent. Kristen.
Yeah, I guess the question I have is how we account for the fact that some of the most needed and highest quality from a, let me see, how do I word this? How do we account for the fact that in many parts of our state, the levels of care that people actually need don't even exist and are perhaps the standard for what we want to have people have access to? So there are levels of care like it's not just about whether you have psychiatrists and therapists in your county. There are types of care and things like residential substance use disorder treatment that is a really important level of care that doesn't even exist for many people in or out of network. It's just not physically present. How do we kind of account for that? Because we can't measure what people can't access if it just doesn't exist.
Thanks, Kristen. Really appreciate that comment. I think one question I might throw out to you and the group for consideration is, whether or not there could be some sort of supplemental analysis that would look at the diversity of providers that are billing for services on a in-network basis, or at least on a covered services basis. I think, that's something that we would likely not do through this data collection, but there may be the opportunity to collaborate with the HPD or workforce or other initiatives occurring within OHCA and its sibling agencies to explore that question. So I'll just sort of put that out to the group as a additional question for consideration.
Mary Jo, this is Beth. If I could just add, I think throughout this discussion, we're going to have a tension between the where do we hope to go and the place we are today, which is really terrible. And I don't know anybody who defends access to behavioral health. We all know we need to do better. And part of this is the where are we going? And all of these cautions, like we don't have data for this, or, or the services don't exist today, are true and right. And they're considerations for how we get to the goal. But some of this is about where are we going?
Thank you, Beth. Any other thoughts or comments on this first question before we move to the second one? I am not seeing any hands raised at the moment. So here is our second question. This asks, oh, I apologize. I missed Amy. Amy, go ahead. Amy, I'm seeing your hand up and it looks like you may be off mute on my end, but I'm not able to hear you. I don't know if others are able to hear Amy.
Can you hear me now?
I can. Thank you.
Okay. I've been having a lot of technical challenges this morning. Thank you. Appreciate the patience.
No worries.
I just wanted to put in the comments for the record in support of Catherine and others, Kirsten, about mentioning the performance and the performance-based achievements and standards, having some sort of quality measurement as part of that question. I think it's really important when we're seeking investment and true investment in the years to come, that there is quality standards by which this investment will be measured. And if this was a business, I think our taxpayers would appreciate that we're measuring, right, achievement and performance standards.
Thanks, Amy.
And then I also just wanted to comment, I missed a bit of the first part. Was there anything about accountability and mentioned at all with respect to the first question and how we're going to really achieve that? I mean, is that really in a quality outcome perspective?
That's a great question, Amy. So there was a little bit of discussion around quality measures and that piece of accountability. We also have as our fourth question a list of potential supplemental analyses that I think will better aim to track, are we receiving the impact or the value that we want out of increased investment? So maybe we could parking lot that question for that fourth question and then see if that's addressing your need there. Oh, go ahead.
Yeah,
I'm happy to do that.
And Mary Jo, I would just add that for our behavioral health investment measurement and spending, OHCA's main accountability mechanism is through transparency and public reporting. So in terms of how we're looking at measuring total behavioral health spend and measuring progress towards this proposed framework for the investment benchmark, we would be publicly reporting progress towards that benchmark, by payer, potentially by payer and line of business, or by payer, line of business and product type, like HMO versus PPO. So that's how that's our main accountability mechanism for the behavioral health work at OHCA.
That's helpful, Margarita. Thank you. And I'll wait for the fourth question, Mary Jo. Thank you.
Sure. And thanks, Margarita. I was thinking of accountability a little bit differently, so that's really helpful to sort of think about it that way as well. All right. So Debbie, let's advance one slide. Perfect. Thank you. So this second question asks how OHCA should structure the benchmark to achieve the aims that we just discussed. OHCA is proposing the approach on this slide. As a reminder, this is related to the benchmark, so not the overall measurement of behavioral health spending. You'll note here that OHCA's proposal is to include spend for in-network, outpatient, and community-based services, behavioral health services, covered by commercial and Medicare Advantage plans. And we will remove that comma after in-network too. The spending would be identified using service codes, revenue codes, and place of service codes. And of course, you know, as appropriate, there could also be non-claims spend there as well. This focuses new investment on high-value upstream care delivery and addresses the lack of in-network access to providers, as well as the resulting consumer cost burden. OHCA would recommend also including telehealth delivery of these services in the benchmark. OHCA is proposing that spending on pharmaceuticals be excluded from the outpatient and community-based behavioral health spend that is included in the benchmark. Including pharmacy would make achieving the benchmark overly sensitive to the unit cost of drugs. There would also be a question of whether to include all drugs in the benchmark or just some. And as we've discussed a little bit before, this question is complicated by the knowledge that the off-label use of some behavioral health drugs for other purposes and vice versa can sort of complicate and fuzzy that spending measurement. In the end, OHCA does not think that increased pharmaceutical spending is a change that should be promoted through the benchmark. One last piece, and then I'll turn it over to a discussion. I also want to note that this segment of behavioral health spending, this in-network, outpatient, and community-based services segment, is small relative to the whole. Focusing on this area as the benchmark highlights its importance and the interest in knowing what is being spent there now, perhaps as a per member per month amount, as well as encouraging increased investment over time. So it looks like we have a couple of hands up. And Nicole, you have your hand up first. Please go ahead.
Thanks. Couple of probably not quick questions, but still questions. I'm wondering if how we're defining outpatient and if that's going to include IOP and partial hospitalization as outpatient. And I'm agnostic to that, but I'd like to discuss. And then I'm not sure, and maybe again, kind of, Beth, I'm piggybacking on your grammar call out earlier, but I feel like outpatient and community-based are actually two distinct things. And unless we didn't mean them that way, so I'd like to put that forward that those be essentially separate, and we talk about the definitions for both.
Thank you, Nicole. So just to sort of recap your points there, and then I think you bring up a really important discussion point for all of us across a wide range of services, which is what's in, what's out, right? Which is, you know, a big discussion. But first to the grammar. So it sounds like you would suggest sort of removing that slash and replacing it with an and.
That's correct. Yeah. Unless there's distinctly a reason we want to combine them, which there might be, and I'm just missing it. But I think those are two distinct categories of care and things that we're trying to independently reinforce.
Mm-hmm. Yep. That makes a lot of sense. With regard to the services that are included, we are going to discuss that in a few slides. We have sort of a straw model list of services from another state, not intending that be OHCA's list of services, but really just using that list to prompt discussion.
Okay.
Yep.
Thank you. Appreciate that.
Of course, absolutely. Kristen.
Yeah, I think slide 19 will probably be a rich conversation around what the list looks like. But I do have some strong feelings about excluding pharmaceutical spending here, and sort of this concept that we need to incentivize spending on things that are only upstream. I think that speaks to, I think, that earlier point that Beth was making around what we might want to see down the road versus what we have today. So on pharmaceutical spend, I think both for our most common mental health conditions, depression and anxiety, pharmaceutical spending is completely appropriate and also far, far delayed. A lot of people don't even get that line of treatment. And so I think we need to make sure we include it for mental health conditions. And then I think for substance use disorder conditions, I think it's become well recognized that medication assisted treatment is the gold standard for many of our substance use disorders. So not really sure why we need to exclude pharmaceutical spend when discussing behavioral health. It would be like saying that we're going to measure cancer treatment, but not look at chemotherapies and other medications that you would treat that condition with. And I think because behavioral health conditions are chronic conditions, only investments on upstream care delivery really ignores the fact that these can be lifelong conditions, that people can get acutely ill and then be in recovery, or have a relapse and then be in recovery. And we want to make sure that people have access throughout the course of their illness to whatever level of care they need, and capture the spending on that, not just sort of hope and wish that everybody gets care early and they never get really sick.
Thank you, Kristen. Hector.
Hi, thank you. I couldn't agree more with the comment just made about pharmaceuticals, especially on the SUD side. I think that's very, very important. There's no way we can talk about our goal towards high quality services and care in the SUD context without access to medications. And I would be even more specific and mention explicitly methadone and buprenorphine, right? And those are the medications that we know have the best outcomes, and where we also know that there's still a lot of work to be done to improve access to those services. So in particular for SUD, I think that's important. And I'm also interested in the conversation around these specific services and IOP. I think that's an important question. I do think that there may be a question about whether the services that we want to see that are a lot of times are provided on an outpatient basis or in a community-based setting are included in IOP settings, and that's it's not always the case. So it may sort of provide mixed results or lead to mixed results if we expand the definition and include those. But I'm open to that conversation. I think it's important that we talk about it. Thank you.
Thank you, Hector. And Parnika?
Hi, I'm Parnika Saxena. I'm a psychiatrist and representing the California State Association of Psychiatrists. I want to echo the point that the two folks before me just made about the risks of limiting or taking into account pharmaceutical spending. I think especially because I know somebody mentioned depression, anxiety, but another big one that we often treat, especially in our sickest patients, is schizophrenia or psychotic. Bipolar disorder, and these illnesses we know are not only chronic and therefore require non-pharmacological strategies, but are very severe illnesses that do require pharmacological strategies. Another thing to keep in mind is that a lot of medications used in mental health disorders are often off-label, and the reason is not because they're not effective. It's just that the number of drugs that are not off-label are actually quite limited. And the reason why a lot of medications that are used are not, labeled, so to say, or approved by the FDA is because it wasn't financially, fiscally necessarily an advantage for a pharmaceutical company to do that study. That doesn't mean that those medications are not helpful. We also
So-
have a lot newer medications, especially antipsychotics coming on the market that are really helping people with treatment-resistant schizophrenia and bipolar disorder, which are already pretty high in pricing, and not being able to get a patient a medication because of a prior authorization that was randomly and arbitrarily pre-decided impacts so many patients. You can ask any physician, not just a psychiatrist, but prior authorizations are a great problem for getting people timely access. So I feel if we are not taking into consideration pharmaceutical spending, we might further cause this problem to escalate, especially in our sickest patients. Thanks.
Thank you. Beth.
Yeah. So here's the challenge that I would raise to the folks that spoke in favor of including pharmaceutical spending. What we know is that all too often, especially when somebody sees a primary care doctor or lacks adequate access, they get a prescription instead of getting the full range of care they need. And so I think we need to have a discussion. I mean, I certainly just heard Parnika talk about the importance of non-pharmaceutical interventions as well as pharmaceutical interventions. I think somehow, if we're going to count drugs, and I appreciate the suggestion, whoever made it, that you can count drug administration without counting the cost of the drug, given how some things are very high cost and lots of drug costs increase. But if we're going to count the cost of drugs, then we need to have something that reflects that a prescription is not the only kind of care that's appropriate in some circumstances, and maybe for mild cases in lots of circumstances. And so I think we just need to, without discounting anything that anybody before me has said about the usefulness of pharmaceutical treatment, whether it's medication-assisted treatment or schizophrenia or severe depression. I don't want to, part of our concern is we don't want to just turn this into an engine for drug spending when it's not appropriate. So we'll just need to find a way through that. Thank you.
Thanks, Beth. So a couple of sort of follow-up questions related to this particular question of whether or not to include pharmaceutical spending. I think part of what we were sort of trying to balance was the potential noise that can occur when including pharmaceutical spending, at least in a broad fashion, because there are a lot of medications that have multiple uses, some of which are to support behavioral health needs, some of which are not. And then also to think about, because of the relative size of pharmaceutical spending, whether or not a significant portion of an overall increase would sort of potentially be eaten up by increases in that pharmaceutical spending, and perhaps not then promote the level of increased access to, I'll say, professional services in particular that some IPW members and other stakeholders have referenced as a need. So I just wanted to give a little bit more background on that. And as Margareta noted in the chat, we did not include pharmacy costs in the primary care definition and investment benchmark. That is very consistent with how all states, there's a few states that include the cost of an immunization, but there is no state that in its primary care investment benchmark includes the cost of drugs prescribed by primary care providers. So with that, Carrie. Oh, go ahead, Margaret. I'm sorry.
Yeah, I just wanted to add in another question or thought for consideration for the work group is, in terms of this investment benchmark, we're thinking about this as where do we want to increase our spending and where do we want to spend more? And would it make sense to have like this specific investment benchmark without pharmaceutical spend while we measure behavioral health pharmaceutical spend separately as a supplemental analysis outside of the benchmark? Or include it in our broader measurement of behavioral health spending as a portion of total spending. So not saying that we wouldn't measure pharmaceutical spend for behavioral health services, but that we're thinking here that it may not make sense to include it in the benchmark that we're looking towards increasing investment because of those reasons and the fluctuations that Mary Jo mentioned. So just another thought for consideration.
Thanks, Margaretta.
Carrie.
Yeah, thank you for the additional context. I think I'm still, getting my head around this. And so it's just helpful to know that, you might still potentially measure this, but this isn't, we're not, that it's actually a separate, treated separately in primary care. And, it's sort of a similar, because I agree with you, like the cost of drugs could, take up all the air. And what we're really trying to do is to increase services. I did want to just, add to Beth's comments that, part of what we see on the quality measurement side that's really disheartening is a lot of measures that sort of tie, behavioral health to providing prescriptions, to giving someone a medication. But when we say we want, more comprehensive behavioral health measures like follow-up care and, 6 and 12 month, remission. I think Minnesota has those types of measures. We often hear, well, that's just too timely and too difficult to measure. And that's, I think to Beth's point, that we want to know, we want to actually see that folks are getting that follow-up care, that they're getting more than just one touch and done. And so, just, to double down, I think on that point and I agree with you on, now that you've sort of talked about this, on really, that focus on where we want to be spending as opposed to where we currently are. Thanks.
Thank you, Sarah. And Parnika.
Yes, thank you. So I don't mean to belabor the point, and I do appreciate that we are thinking more holistically about how to improve access to behavioral health and mental health. But what I think, if there are a couple of things that we should keep in mind. Number one, the point about patients getting a prescription and not getting other things. And I'm not a primary care physician, but I've worked with a lot of them in federally qualified health centers, community health centers. And I can say this with absolute certainty, the kind of patients who don't get referred upstream to let's say a psychiatrist or other clinicians, usually the reason is that there's a lack of a psychiatrist or somebody who has an open panel who can accept patients, right? So that's something definitely we want to increase investment and to have more psychiatrists, to allow psychiatrists who are in private practice to make it easier for them to take Medicaid and Medicare, which right now is a bureaucratic mess, as well as quite, there's no financial incentive because people are often behind in getting their payments and whatnot. But the idea that primary care physicians are prescribing medications, I think that happens probably more in people with mild depression, mild anxiety, who probably don't get referred to a therapist or a psychologist, which would benefit from an overall care. But I can tell you with absolute certainty, people with very severe depression, severe bipolar, schizophrenia, the reason they're not being referred to psychiatrists is not because a primary care doctor thinks they can do it themselves. Most of them, in fact, feel very uncomfortable being in this role, but they don't have any other options. So they're really trying to do their best. It's a little bit like it's a little bit like somebody who has pre-diabetes and somebody who has diabetes and they require insulin to treat. Both those patients do require to, exercise and have a lengthy and a healthy lifestyle. But the the person with diabetes who needs that insulin to survive. Without that, all of this healthy lifestyle is not going to do anything for them. And it's the same with people with severe illnesses who often end up languishing with primary care doctors and end up getting limited care because they don't have access to a psychiatrist. Or I have seen this on time and time again. There'll be a medication that's really beneficial, but it's refused to them, and a primary care doctor does not have enough training to get that prior authorization done. So we definitely need to make mental health or higher mental health more available, but I just want to make sure we don't do that at the cost of not addressing the fact that pharmaceutical treatment should also be taken into consideration. I don't think it should be something we should forget about or think that that's an established thing. It's okay, and we need to focus on other things. I think it should be a parallel process.
Thank you. All right, let's go to Hector.
Thank you, and I appreciate the context as well. Although I would also push a little bit back on the notion that that some of these investment would be sort of noise, right? Particularly in the context of SUD, because it's most of my experience. I think if at the end of the day we see an investment of 100% in a change in an increase of 100% in investment on behavioral health services or SUD services, let's say, and 80% of that goes to specifically buprenorphine and methadone, that may not necessarily be a bad thing. I think that's something that we want to see. That I don't think it's happening right now. I think and I appreciate the comments that have been made about being very, very mindful about all the other services that may be needed. I think that's essential as well. But I think a lot of the things that we see right now in the SUD context is the opposite, where we see a lot of facilities and providers that provide some other services and may not be thinking about medication-assisted treatment, right? And we know for residential services, for example, residential facilities that are not providing medication-assisted treatment, even though it is necessary for people with substance or opioid use disorders. So I think in these contexts, it's just inevitable that we have to account for it in order to make sure that we are targeting high-quality services. And the last thing I would say is that we are also now living in a scenario where at the federal level we got rid of the X waiver. We want to see more providers, more primary care providers having the ability of prescribing buprenorphine for opioid use disorders. And I think the data that we have right now is that hasn't happened. So we're not seeing a sustained increase in the number of primary care providers and other providers that are prescribing these medications. So I think there's still a need to make sure that that's happening. So I will continue to say that it's important that we capture it, even though we have to make sure, as others have said, that it doesn't sort of we don't forget about all the other services that are also important. Thank you.
So Hector, this is Beth. Can I jump? I want to distinguish here between the benchmark and the measurement, because in the measurement we will capture the pharmaceutical. The benchmark is and without discounting anything you had to say, because you know much more about SUD than I do, the benchmark is about where we want to go to. The measurement is about what's going on now. So I think it's hard for my mind to balance both those things, but that's part of what I'm trying to think. We will, in the measurement, pharmaceutical is there because it's part of THCE. And we're actually in a world where for in-network care, sometimes the pharmaceutical is going to be the easy thing, not necessarily the right thing. And I can tell you from having spent too much time on quality measure committees in my life, that tracking pharmaceutical spending is dead easy, and tracking out-of-network spend on things people need is hard. And so I think we have this, behavioral health is a hard challenge. I think my guess is everything everybody here has said describes a reality. And the question is, how do we capture the important parts of all of this in a way that makes sense and moves us forward? Thank you. Sorry to be rude.
No, thank you, Beth. Kirsten.
I think that maybe we need another time to have a kind of deeper conversation about this one, because I feel like there is some disagreement in the group around this issue. And I don't want to lose it. And it seems like it's kind of coming through that the folks who are working on this behind the scenes have kind of made, sorry to be blunt, but kind of have made their mind up around this and feel strongly about the rationale for excluding pharmaceutical perhaps. But I still feel very strongly that for some populations, prescription spending alone is completely valid and is not something we should judge as a thing we should put aside. There are a lot of people who aren't even getting that. While it might be great if everyone had a therapist and medication for depression or anxiety, that's not necessarily the reality. And it's completely valid, again, for people with both a substance use disorder or a mental illness to just be getting prescription drugs. That's valid therapy. So I just want to make sure that while I understand there are some complexities around it, I don't want to lose that thread. And I guess part of what I'm not necessarily following, because I'm not as involved in the OHCA work at large, just really on this behavioral health piece, is what's it really going to look like once this goes live? We're going to look at a website that shows us what exactly that California health plans by name are spending X amount on behavioral health, and we're watching that grow. And there's no ability to drill down into, well, what are they spending it on? So I think that's part of it. Is I'm trying to get a better sense of what will the picture be at the end of this, so that we can better understand what we're able to monitor is growing or not growing.
Margareta, why don't you take that one? Yeah.
Yeah, so I'll just say we, at OHCA staff have not made a, decision or don't have, we have thoughts about this proposed approach, and that's why we brought it to you all, but it is very much a proposed approach. And, your feedback and the discussion in this work group guides how we approach the benchmark and the measurement for behavioral health spending. So we're happy to have continued conversations about pharmaceutical spend and how we approach that, both in the investment benchmark for behavioral health and in the measurement of behavioral health spending overall, and in supplemental analyses that we could do. And then in terms of reporting, we don't have a specific, very detailed plan about reporting, but in terms of overarching, we would report progress towards the investment benchmark by payer, and we would report behavioral health spending by payer. So this focus, if we move forward with this approach, it would be, reporting two pieces plus all of the supplemental analysis that we are considering. So, depending on where we land with both the benchmark and our spending measurement and the supplemental analysis, that we would report those in our OHCA annual report, and potentially other reporting mechanisms, like you mentioned, a dashboard or something on a public website. So I'm happy to continue the discussion on pharmaceutical spend and bring that back in future meetings.
I think that's a great idea, Margareta. So we have a more detailed discussion on what specifics would be included in the definition planned for December. And I think this will be a good topic to bring back. Before we move to the next question, just want to take Dan's comment and then we'll move to the next question.
Thanks. And I just want to I haven't been able to attend every single meeting, so I apologize if this has already been discussed, but I just want to understand the definition of the out-of-network spend. I'm assuming some of that is related to people going and paying cash for services if they didn't feel they could get an in-network appointment or an appointment with an in-network provider. But SB 855 requires health plans to arrange for care with out-of-network providers if they can't arrange the care in a timely and geographic manner with an in-network provider. So would that spend with that out-of-network provider, because they didn't meet the requirements of SB 855, be included in the spend or no? And I'm seeing Beth shaking your head. We would not include that.
It
Well,
would not.
It would,
Go ahead, Beth.
yeah. My understanding is it would be included in THCE because the health plan paid for it.
That's right,
Okay.
but it would not be included towards the benchmark, which I think is an important distinction that we would, want to be clear about. And Dan, I think that's a good flag for us to think through sort of the implications of that law and how that might play out in the benchmark.
All right, thank you.
And sure, no, thank you. All right, let's go ahead to the next question here. So, how should the benchmark be focused is our next question. For in-network, outpatient, and community-based behavioral health services, so sort of thinking about that as our focus area, the idea would be to include mental health and substance use disorders defined broadly, include spending for all behavioral health services received by California commercial and Medicare Advantage members of all ages and in all parts of the state. And that measurement would expand to Medi-Cal when data collection and methodology allow. And so just to sort of restate that, it would be for all spending for all behavioral health services that fell into in-network, outpatient, and community-based, as that is defined later. And for all California commercial and Medicare Advantage members, regardless of age or geography within the state. The third piece is that it would include a set of high-value behavioral health services with limited access currently and the greatest potential to improve outcomes. And as I mentioned a few minutes ago, we plan to ask for your input on which specific services to include or exclude when we begin to look at more details of the definition in our December meeting. I do have a slide that sort of shows you how another state approached this that you can think through between now and the December meeting. We'll talk a little bit about that in a moment. So I'm going to pause here for discussion and would like your thoughts on this proposed benchmark focus. Biggest pieces here that sort of add some more detail to what we had been discussing is that it would be one benchmark that includes both mental health and substance use disorders, and that those disorders and conditions would be defined broadly, that we would be really focused on specific high-value services that currently have limited access and that have the highest potential to improve outcomes, and that it would not be focused on a specific age group or a specific geography within the state. Yes, Kirsten.
Is this the part where we can discuss the earlier comments around combining mental health and SUD?
Yes, please.
I'd like to just hear a little bit more rationale for that, because earlier in the slide deck, it seemed like stakeholder comments clearly said those should be separated. So what is the rationale here for combining them? And I can go into some detail if helpful, but I would advocate that they remain separate and can just wait to make comments about that till we hear from others.
Thanks, Kirsten. I think the additional context I would provide there is that this is proposing that there's a single benchmark and that they would continue, though, to be measured separately. So one of the considerations here is sort of what are we measuring versus what is the benchmark going to look like. And so the benchmark, we're proposing a single benchmark that includes spending for both mental health and substance use disorders. Those would continue, though, as part of broader measurement to continue to be measured separately. One of the pieces that has come up in this conversation previously was to separate them in the benchmark would raise some complexity when we have a lot of co-occurring disorder, substance use individuals with substance use disorder diagnoses and also mental health diagnoses. And so essentially, which bucket would you put in the spend? And you essentially could be making that determination based on the order that the provider decided to put in a diagnosis code rather than sort of what was really occurring within the visit. Does that help answer your question, Kirsten?
Sure. I'm curious to hear other people's perspectives.
Of course. Sarah.
I have a question. So the second bullet, that's what at the next future meetings we will define what high value behavioral health services is.
That's right. I think I would frame it as at the next meeting, we would define what would be included in the benchmark and broader measurement versus what might be excluded.
Okay. Yeah, that is like defining high value behavioral health services. I would just expect that that's going to be a robust discussion because there's sort of, it's probably a wide range of opinions on that, perhaps. On the including of mental health and substance use and lumping them together, I think it's tough. I think for the purposes of one benchmark, it does make sense to include them because we are measuring them separately. And I think it also elevates substance use disorder services on par with mental health services, where often it is not focused on, but we need to just make sure that we are in the measurement, that tracking it, because it does often just get neglected.
Thank you, Sarah. Other thoughts on that? I know that was a question that a few folks had questions about earlier in the meeting. So just want to make sure that we're surfacing any other questions or comments on the proposal to include a single benchmark that covers both mental health and substance use disorders. All right. Seeing no, go ahead. Margareta, were you going to jump in? No. All right. Let's go ahead to our fourth question. So our fourth question here is really focused on, how can we have some meaningful supplemental analyses? OHCA wants its measurement and benchmarking process to be as straightforward as possible for the entities that are submitting data, namely the payers, while still being able to produce meaningful results. And as I sort of referenced briefly earlier, there are other ways to measure whether California is moving towards achieving its key policy aims, for example, by using the healthcare payments database or other data sources. Based on stakeholder feedback so far, OHCA is considering these analyses to supplement its benchmarking. So the first is the proportion of behavioral health services that occur in the outpatient or community-based settings. So essentially, this would be a little bit different, where essentially the denominator would be all behavioral health services, and the numerator would be behavioral health services occurring in the outpatient and community-based setting. Emergency department use for behavioral health needs, rates of behavioral health screening, the number and distribution of providers billing for behavioral health services, sort of incorporating here the comment that we received earlier on the need to also understand whether or not it's a full complement of behavioral health providers. So would sort of add here, consideration of whether or not we need to look at the provider types that are providing services as well. Quality measures such as HEDIS measures that are related to behavioral health care and follow-up. Utilization and cost associated with applied behavioral analysis. We have heard from several stakeholders that applied behavioral analysis is a significant portion of some of this outpatient spending, and so would want to understand that specifically. Spending that is clearly tied to integrated behavioral health, so behavioral health services that are integrated with primary care. The percent of licensed providers that are in network. and then an average number of therapy sessions per member. So one piece that stakeholders have brought to us is that sometimes patients are not receiving sort of continuous or appropriate lengths of care with a therapist. Nicole.
Yeah, I want to actually push back on the average therapy sessions per member, although I think that's an interesting metric to pay attention to. I don't think it equals whether the aim is achieved. Again, I think effectiveness is the focus, and the number of sessions doesn't always correspond to that. Not that but again, thinking it would be interesting to include, just not as part of the, is this working or not? And then the number and distribution of providers billing, and I'm sorry, I cannot remember who said this earlier, but there are, essentially, deserts of access where certain levels of care, certain provider specialties don't exist, telebehavioral health aside. And I'm wondering if, in talking about providers, we couldn't also talk about the number and distribution of facilities at different levels of care. So just to kind of, broaden the definition of providers.
That's great. Thank you so much. Catherine.
Thanks. To follow up on Nicole's, I had a slightly different concern about average therapy sessions, which is that, as we know, we have many people who go once and some people who go for years. And so I think average was the part that concerned me a little bit. I do think there is value in understanding as a measure of access. I was just looking at this for a small sample yesterday, but people who go once and people who kind of, for whom it works, and who, so maybe there's some threshold number, but I do worry about average kind of losing a lot of the detail there. I also, this came up a little bit earlier and maybe I missed the definition. I'm curious I think I understand how we identify outpatient services to that first bullet. What do we mean by community-based here? That was a part I didn't really understand. Thanks.
Sure. Thank you so much, Catherine. I think that is perhaps best explained by looking at a selection of services to get your input on. And we're going to do that in just a minute. And so I might parking lot that one for just a moment. Yes, Hector.
Thanks. Just a minor comment that I would expand the bullet point on emergency department use to include crisis services, since that may have a different focus than ED visits. And it's important in the context of both mental health and substance use.
Thank you, Hector. And Kirsten.
Help me understand what this slide is about. So whether the aim is achieved, meaning whether spending on behavioral health is happening. So where else could we look? I'm not sure I'm quite following.
Sure. So I think what we're hoping to achieve with some of the supplemental analyses is a better understanding of whether or not people are receiving that right care at the right time in the most appropriate setting. So, for example, ideally, if we have better access to outpatient and community-based services, then the need for emergency department use would decrease. Yes, go ahead. I'm sorry.
Yeah. I guess a couple of other concepts to throw out there. One would be to look at issues of equity, both socioeconomically and otherwise, because I think particularly around race and ethnicity, we have a lot of work to do on achieving better access and seeing spending in specific populations increase. And then I guess another area that I think, particularly for psychotic illnesses, there's a lot of interest in the duration of untreated illness, getting people care earlier I don't know how it's kind of different from timely, right? Where I presented and I actually got an appointment within 7 days is different from I had symptoms for 4 years before I actually started to get treatment. So the duration of untreated illness or sort of, the initiation of treatment from the onset of symptoms is another really important issue in both mental health and substance use disorder treatment in terms of looking at access and going to where we're trying to go.
Absolutely. Thank you, Kirsten. Really appreciate those additional suggestions. And let's see, Carrie.
Sorry, internet's slow here. Yeah, I think similar thoughts about kind of the when we think about access, making sure that we're measuring by demographics, language, et cetera. And then I'm also just to the earlier point, looking at the number and distribution of providers billing for behavioral health services, I would also similarly like to see, in terms like what languages are spoken by the providers, sort of what that distribution looks like, because again, I think and demographics, because I think that's something that we want to understand better in and the potential impacts as we think about spending.
Excellent. All right. I am not seeing any other hands up at this time on this question. Thank you all for those excellent suggestions of other places that we could look. We will take these back and evaluate the feasibility of some of these and think about how we might pursue them. And Sarah. Oh, you're on mute, Sarah.
Okay, sorry. On the last bullet, discussion around the denominator in that is important because there are licensed providers who aren't in the pool potentially to be in network, right? So there are licensed providers who work in prisons. There are licensed providers who are retired. And so we need to make sure like that's a tricky one. I've tried to do that in the past. And so a discussion around, you can't just take like the total, I mean, we could, right? And I guess you can just measure it, but no, like, put asterisks by it that there are people in that denominator who aren't actually participating in the labor market.
And I hope one day that we solve that problem across our workforce data. That will be a great day. I think that's a really great call out, Sarah, and something for the team to think about as we would consider how to operationalize some of these and what the phasing might look like. All right, let's go ahead to our next slide. So as I referenced briefly earlier, I was going to review an example of a state behavioral health investment benchmark. And you may say, well, why did you pick this one? And because it's really the only one that we know of that exists, and it's also very new. And so I can't really tell you what success they have or have had because it doesn't really go into effect until next year. But it does give us some food for thought. So this is an example of behavioral health investment benchmark to just show or demonstrate how another state has chosen to focus its benchmark. Rhode Island's Office of the Health Insurance Commissioner, which is sometimes referred to as OHCA, has a behavioral health spending obligation that focuses on spending for community-based behavioral health care for fully insured children and adolescents. So the state of Rhode Island has determined it wants to focus on a specific subpopulation within these community-based services. And they're also going to start by focusing on commercial carriers. So they're not including Medicare Advantage or Medicaid or Medicare at this time. The OHCA spending obligation requires carriers to increase their per member per month spending in 2025 on community-based behavioral health care for that target population to 200% of the baseline. So essentially that's doubling, right? what they currently spend on those services. And this is going to be based on calendar year 2022 data. So if they spent $1 on these services back in 2022, they would need to be spending $2 on it in 2025. So the benchmark's not as daunting as it may seem, because that targeted spending, just community-based, children and adolescents, is low relative to total healthcare spending and even relative to total behavioral health spending. After 2025, carriers must have annual expenditures on community-based behavioral health care for that target population at the market average as determined by OHCA. The benchmark will include claims and non-claim spending for community-based behavioral health care, and it only applies to spending for Rhode Island residents who receive care from providers located in the state. If carriers do not reach the benchmark, then they're going to be subject to some penalties as determined by the commissioner. I want to note that there's not a ton of details yet on sort of the implementation or the specifics of enforcement because they haven't had to do it yet. So they're still kind of working on that. As I mentioned, we wanted to provide you with a list of examples of community-based services that Rhode Island includes in its spending obligation. Please note that similar to OHCA's plans, Rhode Island measures spending on a broad set of services, but it focuses its benchmark on services such as these, and even this is just a list of examples, it's not all inclusive, and also focuses its benchmark on children and youth. We want to put this forward as a starting point for future discussions. There's likely services that should be included that may not be on this list, or services that are on this list that you would say, I would recommend not including. We're going to dive more deeply into this conversation in our next few meetings, but wanted to give you something to sort of, think through and reflect on between now and our December meeting. Yes, Nicole.
I'm seeing partial hospitalization called out. Do we know whether there was ever a discussion in this example about IOP and why that was left out, or just if we know? I don't know.
Sure, a couple of points. So one is, I would say, before I say it's left out, I would want to go back and look. Again, this is sort of examples of the services that are included, not a complete list. It's a pretty comprehensive list of examples, but there may be services that are included.
Yeah, actually, I see it on the left-hand side now, the intensive outpatient.
Oh, yep, right there. I thought it was there. That's why I wanted
about that.
to catch that. No, that's okay. I did think that they included it. So, yes.
Thanks.
Sure.
I think the other call out just really quickly is under collaborative, and not so much to discuss in this example, but for us moving forward, collaborative care management and making sure that we're distinguishing between the use of the collaborative care model and more broadly what we kind of most clinically, colloquially refer to as collaborative care. So just a call out for us to be mindful of those distinctions when we're talking about integrated care.
That's a great call out, Nicole. And I would also ask that you think about, to what extent would you want to include behavioral health services provided in a primary care setting as part of the benchmark? And so I'll just sort of add that to our list of reflection points for the next meeting.
Okay, thank you.
Sure.
And I'm sure we hardly have time to probably go through the robust conversation we can have on this, but would flag that maybe some conversation about the pros and cons of including some of the what I would still consider community-based, but perhaps not an outpatient appointment type services that are still important parts of, I think, high value and evidence-based care, including residential treatment, as well as, I think, some validity around the services that get provided in an ED, I know that we might want to drive people out, upstream, but if we're trying to just capture what's really happening today for many people, especially in parts of the state where there are no providers in the community, is going to the ED. And I think that that's still an important place where people will go to access medication-assisted treatment, initial crisis stabilization, and then a referral. Since we know a lot of people, the primary visit to an ED for behavioral health is a treat and release. So they are getting care there, not necessarily getting hospitalized after. So inpatient psychiatric as well, I think, while we want to hope people will get care earlier, that is, again, back to my earlier comment about this being a chronic illness, that there can be episodes of acute illness, and it's okay for people to have a short stay in a hospital and to count that. So I know we're running out of time, but I'm sure there are other comments people will have of pros and cons around some of those levels of care being counted.
Thank you, Kirsten. One just clarification I would want to emphasize is that there would be a full measurement of all behavioral health services separate from measuring services included in the benchmark. So whether the group and OHCA, whether OHCA chooses to include those services in the benchmark, those services would still be measured as part of the overall spending measurement. All right, I'm going to turn it back over to Margaretta to talk about a few next steps for our upcoming meetings.
Thank you, Mary Jo. So we just we'll go through some quick next steps and preview our December agenda. So this slide, just as a reminder, shows our tentative timeline for our behavioral health work. As a reminder, I will note the one change we'll make here is we ran out of time yesterday in our OHCA board meeting to present an introduction of our behavioral health work to the OHCA board. So we'll be moving that to the December OHCA board meeting, and that is a similar presentation that we made to the advisory committee in October, just introducing our work, introducing kind of some of the preliminary concepts that we talked about when we first started our work group discussions on behavioral health. And then in terms of our next steps for our work group, we tentatively for December plan to review and discuss preliminary draft recommendations for approach to measuring claims-based behavioral health spend. So really diving into, what are the services that we would include in both potentially measurement and the investment benchmark for behavioral health. So we'll focus on how we're defining claims-based behavioral health spend in December. And I think we'll wrap up. Again, as always, we look forward to seeing you in December. Our meeting is on December 18th. Feel free to reach out if you have any questions or comments in between meetings. We're also happy to connect to have further discussions on any of the concepts we raised today with you all between meetings. So feel free to reach out. And thank you very much for the robust discussion. As always, we really appreciate the discussion and helping us guide us through this complicated work. So appreciate all the engagement. Thank you all, and have a great Thursday.